support through this process. So I will share my slides. Okay, so as Monica mentioned, my project was around machine learning algorithms in health and its impact on the racialized population. And so in my presentation today, I will give an overview of my project objectives, speak to briefly what machine learning is and how machine learning algorithms work. Then I will speak to different fairness measures that are discussed within the literature, and then dive into one specifically using a case study. And then I will conclude with some key takeaways and some of my concluding thoughts. And so my project objectives. So I was really interested, or my interest in machine learning, or just in general technology and health, stems from my graduate capstone project, which I did with TELUS Health. And essentially I was working on, or I was supporting the introduction of their new mobile health app, Babylon by TELUS Health, by doing an independent research study with physicians across the GTA to kind of learn what some of those adoption barriers could be when it's actually implemented. And even though this work or this app seemed so innovative, it was very convenient. Through many conversations, I realized or learned that there are many barriers to technology adoption around issues of like digital literacy, health literacy, access to tech due to financial constraints, and whether the assessments could be done accurately virtually. And so in the end, I learned that interventions like this can produce additional barriers, especially for those who are part of equity seeking groups. And after this work, I was just very intrigued by the way health and technology intersects. I always kind of knew about TELUS in regards to phone and internet, but I didn't realize that tech companies are quite integrated into our health system. And so it was just very interesting to me that there's fields that study health processes and health equity through technology. And then later that year, I came across striking news in the media around machine learning biases in health, and particularly around its impact on Black patients. And so when I seen the opportunity to do just explore research through the Data Toronto workshop, I thought it would be really cool to kind of dive more into this concept and learn about how bias shows up in health technology. And so for my project, I did a literature review to introduce these concepts of machine learning and algorithmic bias and demonstrate its impact on the health of racialized communities, and then explore whether current measures of fairness sufficiently address some of the discriminatory outcomes that the research shows. So what is machine learning? Just a brief definition. Machine learning provides systems with the ability to construct or create algorithms that can learn from data inputs. And so essentially algorithms use large data sets to answer big questions and improve the efficiency of healthcare delivery. And so this can improve early diagnosis or detection of complications and just overall health outcomes and how patients are cared for. So I put together this very simple diagram about how this process works with machine learning algorithms. Usually starts with the data set and the data is fed into some model and then the model uses the data to kind of, or the model uses the data to create and inform how it makes these predictions, and that process is referred to as training. And then when that happens repetitively, the model is then able to create predictions based on that data set. And over time, as more predictions are created and as more data is gathered, this model kind of does this process in training, fine-tuning, to ensure that there's more accuracy in the prediction served by this model. And so this is a seamless process, and if done correctly, it could actually ensure processes are quite efficient, but over time, many have realized that biases could occur at different stages, which could then produce inaccurate predictions. And so here I kind of just put different biases that could occur at each stage. For the sake of time, I won't go through each of these biases. Within my literature review, I do speak to them in a little bit more detailed, but through the rest of my presentation, I will share examples of some of these. And so now I'll go into fairness measurements. And so in my literature review, I put together this table to kind of speak to the different definitions, strengths, weaknesses, bias implications, and examples of different fairness measurements that are used within research. So in my review, I speak to just 3, but there are several different formal definitions of fairness. And so I will briefly explain what anti-classification is, classification parity, and calibration, but with my case study, I will dive more deeply into the definition of calibration. And so anti-classification is when social identities such as race, gender, or anything around socioeconomic status is not explicitly considered or referenced within the algorithm. And so the pro of this is that decisions have no explicit dependence on the history of, or does not have any explicit dependence on a group's membership to a particular identity. But the con is that leaving out critical information could lead to discriminatory decisions. And this quite aligns with representation bias, which is when your data set is not actually representative of the population that it's actually, I guess, assessing in practice. And so a good example of this is when machine learning is used within dermatology field. A lot of literature speaks to some of the absence of diverse populations within the data, which can then lead to misdiagnosis for people of color with non-existent skin cancers, or you can miss some of those signs quite early. The second one I'll speak to is classification parity. And so the definition of this is when the proportion of positive predictions are the same across all groups, providing the same level of risk. And so this is when you're essentially just choosing one error metric. What's commonly used is the positive false to see which groups are at greater risk. And so the pro of this is that it facilitates a more equal assessment of harm for each individual across the metric that you're studying. But the con is that the distribution of risk could easily vary due to the differences in error rates. And so this aligns with aggregation bias, where incorrect conclusions arise for a particular subpopulation based on observations seen on another population. And within the literature, diabetes is a great example of this, where sometimes physicians provide the same treatment for different diabetes patients, but the biomarkers are different across different ethnic groups. So sometimes it's important to sometimes when you kind of have a same treatment level across for a particular health outcome, it doesn't necessarily have the same effect for different people of different groups. And the third one is calibration. So this is defined as when you adjust the condition to hold simultaneously for individuals within each group and compare their predicted probabilities for that particular outcome. And so the pro is that this creates a model that represents true probability of the occurrence of that outcome. But the con is that you can misclassify individuals. You can misclassify individuals to a false outcome that doesn't necessarily reflect that reality. And so an example of this is measurement bias, where you're not necessarily measuring, you don't have the correct measures for the population, or you're not measuring what you're hoping to see through this work. And so an example is enrollment differences in high-risk care programs, which I will speak to more deeply in the case study to follow. So my case study will focus on a paper called Dissecting Racial Bias and Algorithms Used to Manage the Health of Populations by Obermeir et al. And this was published in 2019. So this study explored the issue of how healthcare systems are often overwhelmed by patients who have complex needs. Often what happens is that patients who require more intensive or critical care can easily fall between the cracks as these hospitals or healthcare centers are overwhelmed. And evidence shows us that patients tend to worsen over time, or these patients tend to worsen or deteriorate over time quite quickly, which causes more emergency visits or early mortality, which then has implications of cost on the actual healthcare system. And so if healthcare providers are able to detect who these patients are at an earlier time or at a quicker rate, they can prevent the acceleration of poor health. And so high-risk management programs have been developed to accelerate the detection of these patients to prevent and mitigate future risk while solving the cost, and algorithms allow them to detect this at a more quicker rate, especially when there's overwhelm, when the center or healthcare centers are overwhelmed. And so the objective of this study, the researchers wanted to quantify racial disparities, use in a commonly used algorithm for this type of program, and identify the mechanisms that racial biases arise. So what they did was they trained this algorithm on a national data set of insurance claims and lab data. So the sample was made up of 49,618 patients. 12% were Black, 88% were white, and Black were those who self-identified as Black, and white were those who self-identified as white and not with any other racial category. And so what they did was they produced algorithmic predictions for different health measures to compare the number of Black and white patients who qualified for these high-risk programs. And so they used different calibration methods to equalize the algorithmic prediction and show the differences in the number of patients who qualified for this program compared to those who qualified prior to this calibration process. And then they took a further step to calculate and compare the distribution of cost among Black and white patients within those predictions, but also across different health outcomes. And so what they found was that at any level of health based on the algorithmic prediction, so in table A, Black patients tend to have more chronic conditions and therefore are more likely to suffer poor health. So the Black patients are the purple line, and as you see across each score, they have more active conditions. And then the authors also, once they calibrated this algorithm, they found a substantial increase of the number of Black patients who would qualify. So with the original algorithm, it was 17.7%. And once they calibrated, this number almost more than doubled to 46.5%. So we're seeing more than half of Black populations are falling between the cracks. And then when they also kind of looked at when they also compared the cost, so they found that there were small differences in the distribution of medical costs for Black patients versus white patients. So as you see in diagram A, there's not much differences in how much is being spent for Black patients versus white patients. But then when they took it to another level and looked at the cost per illnesses or within each different type of illnesses, they found that there's at any given level of health, Black patients tend to generate a lower medical cost. And I believe, for example, if there was a Black and white patient who both had the same degree of renal failure, you would see that less than or $1,800 per year was less spent on Black patients than white patients. And so the mechanism of biases that the researcher spoke to was one, the inaccuracy of labels. So they found that this algorithm was actually predicting cost rather than predicting health. And as you can see, cost isn't a good proxy for determining health, because here you're seeing that's the same, but here you're seeing that the health is quite different across each patient. So there is some kind of discrepancy in, or cost is not really telling us the degree or the severity to which the individual requires additional help or support. However, it is clear that if it was measuring, the label was measuring costs, so it did do what it was supposed to do, but the issue is that discrepancy between what the algorithm is set to measure versus the purpose of the program that the algorithm is creating predictions for. And then the second mechanism of bias was around disparities in access, which is often mediated through the social determinants of health. And so in this study, the racialized group of focus was Black patients, but as we know, or evidence does tell us that poverty is racialized. Black, Indigenous, people of color tend to have poorer outcomes across all the social determinants of health that do influence our ability to access care. For example, if you live in a rural area, you may not be able to have access to transportation, or you might have transportation challenges to attend your appointments. If you live in a food desert, you may not be able to have access to the healthy foods that you need to maybe change your diet for your health condition. If your work is precarious, you may have to take on additional work so that you could, or so that if you do have to take on additional work, you may not be able to attend your appointments, for example. And so a lot of these disparities in care often have to do with those social factors that have a big role in our health, but also our ability to access support. And lastly, they spoke to disparities in treatments. And specifically for the Black community, there's a lack of trust with the medical care system, and many do undergo poor interactions with healthcare providers. And in this work, they speak to how this stems back into the Tuskegee study, where Black men were subjects of syphilis studies and were not given all the facts about the side effects of the treatment. And when there was penicillin available, most of them were not able to get the treatment for support. And with this study, a lot of people kind of speak to how researchers drew upon the perception of about primitiveness of the Black life, and the idea of bad blood to kind of justify the maltreatment at that time. And we see that these same stereotypes or misconceptions about Black health or Black pain or Black people in general continue to be ingrained within our culture and do subconsciously influence how people are treated, or, for example, how they receive care. And so I guess the lack of trust then kind of leads to a lot of critical information being left out in people's interactions with care or with their healthcare providers, which influence the types of treatments that they probably receive. And I also even noticed, like in my work at a mental health center, I do predominantly work with Black community, but even as somebody who identifies as Black, it does take a lot of time and effort to build relationships with people so they can truly express their health needs. And even when that is expressed, they still kind of hesitate to give more information, for example. So I can imagine within like emergency offices or emergency departments, or just within the healthcare system where they're overwhelmed and doctors are quite busy, there's no room to build that relationship or put efforts to bring down those barriers. And so some of my key takeaways from this work is that current fairness measurements are not sufficient in detecting discriminatory decisions. It's there needs to be more work to kind of look deeper into like what these predictions mean, and truly contextualize these meanings to the realities of people and the target population. The second key takeaway is that label biases are a key factor to reducing biases within algorithms, and this is in relation to how we formulate our problems. For example, with the case study, the issue wasn't necessarily with the algorithm itself because it did what it was labeled to do, but the issue was more so the problem that the algorithm was addressing did not necessarily align with what that label was designed to do. Another key takeaway is that there is a need for a collaborative nature at each stage of the ML cycle. So from the designing to the training to interpretation, to allow for greater transparency and accountability. Again, with the case study, I think it worked really well because there were so many different players as part of that work where they were working with the algorithm developers, they were able to access the inputs and the outputs. And so they were able to actually kind of dive deep into what those mechanisms were. And the benefit of that is that now these researchers are able to kind of work with those developers to fix this issue at its core, which can then influence other developers to do the same. And then lastly, there's a need for more, I guess, policies or just understandings about how the social determinants of health relate to access of care. Um, I know according to the Canadian Medical Associations, they say 60% of our health is attributed to those social factors. And even in the pandemic, we're seeing that those who have poor housing, who have to take public transit, who are food insecure, essential workers, cashiers, PSWs are disproportionately affected, and it's not necessarily because of the biological makeup of their health, but it's those social factors. So I think it's important to integrate our understandings of how we interpret these predictions and how we develop interventions to address what these predictions tell us. So for example, if there's issues around, if there's like issues around transportation, or for example, in my work, like I noticed that a lot of people who are homeless, they cannot kind of access care because they can't drive themselves to the center, even if I see them 5 minutes away, or they can't. So maybe a solution around this or intervention could be to provide like ride sharing options, or even for those who are doing precarious work, providing grants or subsidy supports to allow them to access care. So kind of connecting those interventions to the broader social determinants of health. And so some of my concluding thoughts is that data is a critical component to all of this, because it helps inform everything, but also machine learning could also allow us to see what those hidden insights are in data. So it's really important to not just look at algorithms or how they're trained or those mathematical approaches to uncovering biases, but it's important to kind of understand how it shows up in the data. And even when data is representative of the population that you're studying, kind of reflecting on those underlying societal historical biases for a particular population to kind of better understand how it's going to inform that training process, which then speaks to my last point around, or my second point around the importance of recognizing these histories of discrimination and how they exist within digital platforms. So kind of just not using data at face value, recognizing that there are new and nuanced ways that these data could make up the logic of how these algorithms perform. And so in the future, approaches to measuring fairness could attempt to predict how non-medical factors, so those personal interactions or those historical understandings influence health outcomes and how people access care. And so just kind of going back to this diagram, it's really important that we kind of understand what the data is, what kinds of data are feeding into these models and this training process, because it is the key to unlocking insight, but it's also the key to making machine learning probably produce inaccurate predictions. And so as Monica mentioned in the beginning, I did create a literature review and repository of key sources that were part of my literature review. And so you can see that at GitHub on this website here for more information. And yeah, that's the end. I just want to say thank you for everyone for listening. Thank you for Toronto Data Workshop for this opportunity. And again, thank you to Monica and Jessie for your support and guidance through this process.